Well, welcome everyone to the November 28th. I think it's 28th now. November 28th, 2011 EKG case of the week. I realize that your screen says November 20th, and that's from last week. We're going to do a continuation of what we started talking about last week. So we'll just quickly go through the slides that we covered last week, and this had to do with WPW syndrome, and we started out with this case, a 26-year-old man who presented to the emergency department complaining of some lightheadedness, and he had an irregular rhythm, so we're thinking atrial fibrillation, but you notice that the complexes are changing in morphology, and in some places they are extremely rapid. And then what we did was we went on to review the basics of Wolff-Parkinson-White syndrome. We talked about the classic triad: short PR, slightly wide QRS complex, and the delta wave that everybody always loves to talk about. And we talked about basic normal conduction. We talked about what happens when you have an accessory pathway and how that influences your conduction. And again, if you don't remember this stuff, just go back and review the case from last week. I'm just going to quickly move through this so we can get on to the most important topic, and that is atrial fibrillation. But last week we did cover the orthodromic SVT, and as you recall, orthodromic SVT is when the impulse is going down the normal pathway and then using the accessory pathway as its reentrant limb, and you get this circuit movement, and it produces a regular narrow complex tachycardia. And then there's the antidromic SVT, where the impulse is going down the accessory pathway and then back up the normal pathway, and the result is a wide regular tachycardia. And I mentioned that treatment of the SVTs is really not that big a deal. If you have narrow regular, treat it just like any other narrow regular tachycardia and you'll be fine. If you have wide regular tachycardia, treat it just like any other wide regular tachycardia, which you're going to assume is VTAC. And if you treat these like VTAC, you're going to end up doing fine, especially if you use amiodarone, procainamide, or if you just shock the patient. If you happen to use lidocaine, it's really not going to help, but it won't hurt either, fortunately. So the main problem comes up when a patient with WPW develops atrial fibrillation. So SVT, again, is not the big deal. It's atrial fibrillation which is a big deal. And now we're going to talk about why. First of all, let's just take a look at what normally happens in normal rapid atrial fibrillation. So this is the AFib patient that you and I see probably a couple times a week. It's probably the most common sustained tachyarrhythmia that we see. A lot of people out there have AFib, as you know. What's going on with normal atrial fibrillation? So this is a patient who has no WPW, okay? Normal atrial fibrillation. The atrium is beating 3, 4, 5, 600 beats per minute. There's multiple foci within the atrium that are firing impulses, and the impulses head down the normal pathway. You try to go down the normal pathway, and because the impulses that do make it down the normal pathway hit the ventricle through the His-Purkinje system, which is a very efficient, rapid conduction, you end up with a narrow, irregular tachycardia. Now, here's an important point to keep in mind. If the atrium is beating 500 or 600 times per minute, what's the normal ventricular rate that we're accustomed to in rapid AFib? Well, normally when we see rapid AFib, we see the ventricle beating about 150, maybe 180, in rare cases maybe up to 200 beats per minute, but that's normally what we see with patients that have rapid AFib, right? The atrium's beating 500 or 600 times a minute, the ventricle's only beating about 150 to 200 beats per minute. Have you ever wondered what happened to the other 350 or 400 beats? I wonder that all the time. Well, maybe you don't, but let's wonder that right now. Well, it turns out that where did those beats go? It was the AV node that squashed them. That's one of the really great functions of the AV node. It will only let a certain number of impulses down to the ventricle. It's very protective to the ventricle, so that AV node is very important. The atrium is beating 500 or 600 times a minute, but the ventricle only sees 150 to 200 of those beats. All the rest of them got killed by the AV node. So it's a very, very important function of the AV node. Now, when a person has an accessory pathway, they've got WPW, well, you've got a lot of beats that are heading down the normal pathway, producing narrow QRS complexes. You've got a lot of beats that are heading down the normal pathway, getting squashed by the AV node, but you've also got a lot of beats heading down this accessory pathway. Notice what we said last week. The accessory pathway has no AV node. As a result, every beat that goes down the accessory pathway will be conducted. The accessory pathway is like grease lightning. It'll conduct everything it sees. And also what we mentioned last week is that any beats that go down the accessory pathway produce very wide QRS complexes. So what you end up seeing on the resulting rhythm is you've got some complexes that are very narrow, some complexes that are very wide, some complex, I know my drawing is really awful, some complexes are narrow, some are wide, and then some are combinations of fusions between the two. These are beats that went down the normal pathway, these are beats that went down the accessory pathway, and the combination, the middle QRS complex morphologies, those are just fusions between the two. And the resulting rhythm is irregularly regular because it's AFib, with morphologies that are changing. Some narrow, some wide, some are in between. And in some places, you might get rates as fast as 250 or 300 beats per minute because that accessory pathway exists and it is so happy to conduct everything it sees. And the result is that when you've got patients that have AFib with WPW, you end up with very, very rapid rates. And if you don't look carefully, you may look at it and to the naked eye, it kind of looks regular, but look carefully, you'll see it's actually irregularly irregular. And if you mistakenly think it's regular, you may end up mistakenly calling it SVT or VTAC. And if you're not thinking WPW, you may mistakenly just think it's a plain old bundle branch block instead of WPW. But the results of any of these three misdiagnoses can be deadly. Let's look at some examples here. Okay, so AFib with WPW, looking at some examples, you'll notice here it's irregularly irregular, so it's atrial fibrillation. Notice in some places the rate's approaching 300 beats per minute and the morphologies are changing. Here's another example. Notice that it's irregularly irregular. Now, take a moment. You might take a quick peek at this and say, well, that kind of looks like VTAC, but it can't be VTAC because if you look carefully, you realize that it's irregularly irregular, okay? So it can't be VTAC. This is irregularly irregular. VTAC has to be regular. VTAC's like clockwork, regular. This is irregular, so it's AFib, and the morphologies are changing, and in some places, again, you've got rates approaching 300 beats per minute. All right, here's another one. Notice it's irregularly regular, rates in some places approaching 300 beats per minute, and the morphologies are changing. Here's another example sent to me by a friend in Missouri, Chuck Shepard. This is a young patient that was having near syncopal episodes. It's irregularly regular, morphologies are changing, and in some places approaching 300 beats per minute. Here's another example. All right, this was sent to me by recent graduate, emergency medicine pediatrics graduate Adam Friedlander. Was working one day, minding his own business in the emergency department one day, when suddenly, from out of nowhere, a patient comes in with AFib and WPW. It's irregularly irregular, the morphologies are changing, and in some places the rates are approaching 300 beats per minute. He ended up shocking this patient, I believe, and you'll see that after the patient got shocked, went back to science rhythm, and you notice the nice short PRs, the delta waves, and so on. Good job, Adam, if you're out there listening. Another example, irregularly irregular, morphologies are changing, and in some places rates approaching 300 beats per minute. There's got to be an accessory pathway when the rates approach that fast in atrial fibrillation. Now, I'll tell you what happened in this case. The physician took a look at this and said, well, here's a young person with a wide complex tachycardia. Well, you know what? Let's try some lidocaine. Lidocaine didn't work. And then he said, well, you know what? Let's try some adenosine. It's a young person. Maybe it's some type of SVT, and technically AFib is an SVT, right? But he tried some adenosine, and here's the rhythm strips associated with this patient. The patient gets 12 milligrams of IV adenosine, and sure enough, adenosine kicks in about 10 seconds later, and the patient goes right into ventricular fibrillation. This is what deadly occurrence can occur. Occurrence can occur, that's redundant, but this is the deadly thing that can happen when a patient gets a potent AV nodal blocker in the setting of AFib with WPW. Now, what exactly happened here? If you look at the diagram I just showed you a little while ago, all right, remember what we said, 500 or 600 beats up here, a whole bunch of them are coming down here producing narrow QRS complexes, a whole bunch are coming down this way producing wide QRS complexes, but hundreds of them were getting killed by that AV node. The AV node was doing a good job there. Now, what did you do? You gave the patient an AV nodal blocker. You took out the AV node, and so now where do all those beats decide to go? They go right down the accessory pathway, which is all too happy to conduct everything. So now instead of a rate of 200, 250, maybe 300, you suddenly have a rate of 500 or 600 beats per minute. That's called ventricular fibrillation. All right, let's look at another example here. So this patient, again, if you glance at this, it kind of looks like VTAC, but look carefully, it's irregular. So this has to be AFib, and the rates are approaching in some places 300 beats per minute. The morphologies are changing. This is AFib with WPW, not recognized by the physician. It was a young person, so they decide once again to give some adenosine, potent AV nodal blocker, and about 10 seconds later, the patient goes right into ventricular fibrillation. All right, sometimes we facetiously refer to this as a clean kill. It's a very reliable way of killing a patient, okay? And what I just showed you a few minutes ago on that diagram, let me see if I can find that diagram. There we go. There's the diagram. Oh, there we go. Okay, so remember what we said about adenosine. Potent AV nodal blocker, it knocks out the AV node, and all of those impulses just head down the accessory pathway from a functional standpoint, all right? The same thing happens with adenosine as what happens with calcium channel blockers and beta blockers. All of those are potent AV nodal blockers. DIG does this also. DIG takes a few hours to work, and case reports have shown that when these AFib WPW patients get digoxin, they go into VFib a few hours later. So any AV nodal blocker is going to put these patients into ventricular fibrillation. It is a deadly, deadly, deadly thing to do. So you never want to give an AV nodal blocker to anybody who's got AFib with WPW, or this is what you're going to end up with. Go right into ventricular fibrillation. Okay, now going back to the case that we started with, 26-year-old nurse that I was working with one day who had palpitations. We got the EKG, and he's got an irregular rhythm, so it's AFib. The morphologies are changing, right? And in some places you're approaching 300 beats per minute. So this is AFib with WPW. I offered to shock him. He said no. So we ended up giving him procainamide. He got admitted. Procainamide worked beautifully, and he ended up getting ablation, and he's doing fine. Here's another example, and this was seen over at Mercy Hospital by one of our colleagues. It's irregularly irregular. Notice the morphologies are changing. Only in some areas do you get really, really fast. But again, the morphologies are changing. So this can't just be a bundle branch block. Morphology is changing this much. This is AFib with WPW. This patient got procainamide, worked beautifully. Now, let me show you this case, all right? This was in our ED. It's irregularly irregular. Morphologies are changing. In some places, 300 beats per minute. So, right, this is a no-brainer to everyone now. This is AFib with WPW. If you look in the AHA manual, the ACLS guidelines, they say go ahead and give, you can shock the patient. That works beautifully. You can use procainamide. That works nicely. One of the other options they give you is amiodarone, right? We fell in love with amiodarone in 2000. People started using amiodarone for everything. I think people were using amiodarone for erectile dysfunction, for all you know. I mean, everything. If you see a PVC in the hospital, you just start flooding the water with amiodarone. That's how much people fell in love with amiodarone back in 2000. Not so good. Well, this patient got amiodarone, and just like ACLS said, amiodarone, and what ACLS didn't tell you is that this can happen with amiodarone. The patient went right into ventricular fibrillation. Fortunately, the patient got shocked out of it and ended up surviving. But then people said, why is it that amiodarone's caused a problem in this patient? So we reviewed the literature, and if you review the literature, it turns out that the only published literature on amiodarone in rapid AFib and WPW shows adverse consequences. These are just some of the case reports that are out there. This last article by teaching Ellis from some folks down at LA County, including I think Mel Herbert was involved in this publication as well. And this was a nice review article that talked about a lot of these case reports, and there's really no good data. There's no literature saying that if you have rapid AFib and WPW and you give amiodarone, the patient does well. There's no case series or case reports or research studies that I can find. Despite that, it still ends up being put into the guidelines without any good evidence, without any evidence, period. And all the evidence that we see out there is that amiodarone is dangerous. Now, why would amiodarone be dangerous? Well, if you take a look at the physiology about regarding how amiodarone works, amiodarone is actually primarily a class 3 antiarrhythmic, which means that it influences the potassium channels, is considered an antifibrillatory agent. But in reality, amiodarone is part class 1, class 2, class 3, and class 4 antiarrhythmic. And if you remember what class 2 is, it's beta blocker. Class 4, calcium channel blocker. In other words, amiodarone is part beta blocker, part calcium channel blocker. In other words, amiodarone is an AV nodal blocker. And so once you realize that, it's not surprising that the literature says that amiodarone can actually be dangerous. So my recommendation, based on the literature, is that stay away from amiodarone if you ever have rapid AFib and WPW. There's no actual good literature to support it. Now, remember how we said that irregularly irregular with changing morphologies and rates in some places approaching 300 beats per minute is WPW. What does AFib with the bundle branch look like? Well, this is AFib with the right bundle. You don't have to worry about WPW here. Why not? The morphologies are pretty much the same. Nowhere are you approaching 300 beats per minute. So I'd feel perfectly comfortable treating this patient with an AV nodal blocker. I'm not worried about an accessory pathway because the morphologies are all staying the same. Here's AFib with a left bundle branch block. And notice once again, the morphologies are staying the same, and nowhere on this are you approaching 300 beats per minute. I'm not worried about an accessory pathway here. I'd go ahead and give this patient calcium channel blocker or beta blocker, no worries. All right? And here's another patient with AFib with the right bundle, once again, sent to me by EM Peds grad from a couple years ago, Heidi Fahrenholt, AFib with the right bundle. Notice the morphologies are all staying the same, and nowhere on this are you approaching 300 beats per minute, so I'm not worried about an accessory pathway here. Sure, go ahead, give them a beta blocker, calcium channel blocker, give whatever you want. AV nodal blockers are fine here. But if the morphologies are changing, here's another one, by the way, AFib with just a non-specific interventricular conduction delay. I'm not worried about an accessory pathway here because the morphologies are all staying the same, and nowhere are you approaching 300 beats per minute, so I'm not worried about an accessory pathway. This was sent to me by a friend down in Florida, Dale Birnbaum, who runs the Florida Emergency Physicians residency program down there. All right, but when you've got morphologies that are changing, and in some places you've got rates that are approaching 300 beats per minute, you've got to worry about that accessory pathway and stay away from all AV nodal blockers. The best thing you can do, if they're stable, give them procainamide. If they're unstable or borderline, just sedate those patients and give them a quick cardioversion, and that works very, very nicely for those patients. All right, so AFib with WPW is the deadly rhythm that WPW patients get. Stay away from AV nodal blockers. When in doubt, just shock them. It's a great way to go. All right. Well, that's it for this week. And between last week and this week, I hope I've been able to shed some light on WPW and the tachydysrhythmias that WPW patients get. SVT, no worries. WPW, worry a little bit. Give them procainamide or shock them. That's it. Talk to you next week. Thanks a lot.